irony is that that information is available on whether or not patients fill their medications. We don't know that they take it, but I presume if they're refilling it, they're taking it. But you can look at the medication possession ratio, and you can, but who's looking at that? I have the data. We actually publish the data on all patient medications, oral medications that are filled, and I sub-Q administered sub-Q administered medication, so you can look at refills of a Humira or anything else. But physicians don't use it. Do they know what's available? We need to do a better job of making sure that physicians have access to that data. And one of the benefits, I think, of physician-dispensed orals is you have much, at least that data is in your hands.
Right, right.
Or at your fingertips.
Exactly. I mean, I think that's one of several benefits, but you're right. And of course, I mean, we get some hint based on what side effects or what lab abnormalities that we're seeing, you know, in the patient's record and so forth. But again, you know, we don't live with the patient, so we don't know if they're actually taking the drugs or not. But I would think that if they're getting the medicines refilled, that, you know, for the most cases they are taking the drugs.
So does Priority have its own specialty pharmacy?
No, we do not.
You don't. Do you contract out to a specialty pharmacy?
We have a single preferred specialty pharmacy, yes.
And do you believe that the specialty pharmacies do a better job of medication therapy management in general than physician practices do?
I don't have any evidence to support one way or another.
You are so tough.
Okay.
I didn't ask you what the evidence was. I asked you, what do you think?
What do I think?
Yeah.
I don't know, because we're not tracking the relative performance of one versus another.
I mean, do you think as an industry, the industry believes that the specialty pharmacies do a better job? Do you think that they believe physicians can manage this?
I think specialty pharmacies are more focused on medication therapy management and compliance than physician practices, certainly. Right. Although in a dispensing pharmacy at a practice, there's a pharmacist there who could be tasked with that job. But I think the challenge still is who's got time to do that and who's where are the incentives. And if there's an incentive on this part of a specialty pharmacy to manage compliance, they'll do it.
Well, I would argue that especially pharmacists also, you know, have the time, energy, and wherewithal to get in front of the payers and argue their case better than what us private practice physicians do that have in practice retail pharmacies. So,
so what do you want to get in our faces for?
Yeah.
What else? What else? What else do you want to get?
To beat you over the head and say, you know, send all your scripts to us. I mean, which is what the specialty pharmacies do.
Yeah. Yeah.
But you believe that practices can do as well or better?
Yes, I do.
So today, Medicare pays for medication therapy management. A lot of health plans, including ours, are paying for medication therapy management, not only for Medicare because we're required, but also for our commercial and Medicaid beneficiaries. So there's no reason, in fact, many of our practices who are dispensing pharmacies do get paid for medication therapy management. So there's someone who can not only do the med reconciliation and do the compliance, but also get paid for it.
Right.
So that sounds like it's not universal in terms of what payers have adopted. The fact
For
that
commercial patients, right?
For a commercial
Yes.
patient being treated in a dispensing practice.
Right.
But that could be something that if it was more universal, could further support what you believe is the better avenue, that for the physicians directly work with the patient.
And support those practices that don't have in-house dispensing pharmacies as well.
Now, one of the things that's happening is, especially in the oral space, because we got precision targeted therapies that often focus on very ultra-orphan populations, is the manufacturers moving to very limited distribution models. Yeah. And sometimes it could be a sole source distribution model, exclusive arrangement. So does a payer have do you have an issue with that? Is there any impact to a payer in that design?
In our setup, patients who are getting drugged through the specialty pharmacy go through that single specialty pharmacy, and that specialty pharmacy will get it from the distributor, whoever that is, even if it's a single specialty pharmacy.
Wait, say that again. So if you have a contracted preferred specialty pharmacy,
yes,
but they're not the specialty pharmacy that was
choice
selected,
for that
choice
drug,
for that manufacturer, they will still get it and make that distribution?
Correct.
All right. I
And
didn't realize they could.
Yeah, that limits the frustrations that physicians have in contacting 15 different specialty pharmacies, at least for our plan.
But that doesn't happen for you. If there is a restricted model, and that would restrict your practice from being able to dispense.
Yes, assuming that we're not, within the distribution channel, correct?
Right. And so, and do you have a sense right now, kind of the product mix? And you mentioned the 70 orals. How many of them, hopefully it's a small number that you can't dispense through the practice?
Well, I can give you a percentage of the oral oncolytics that we can or can't fill. We can fill 60% of the scripts that we write, and 40% are mandated through the payer to go to their specialty pharmacy.
Mandated through the payer.
Correct.
Not because it is a manufacturer relationship that has a single source distribution or a limited distribution network.
That's right.
All right.